Okay, good morning. To first share with you a discovery I have made since being in Poland. Yesterday morning I felt fairly awful. Maybe this was the jet lag, but last night, well, this morning I feel much better, and I attribute that to the hospitality of my hosts. Polish fruit liqueurs, they're amazing. I feel so much better this morning, and after only 5 glasses, it was quite a miraculous thing. So thank you once again to our hosts. You're looking after us remarkably well, and the more we drink, the better we feel. There's going to be considerable overlap with Jerry's talk, but I think hopefully this will work well, and we'll get a complete understanding of what hypoxic ischemic encephalopathy and cooling is all about. To put this in perspective, it's a big problem. It's a big problem for us in the developed world, and it's a big problem worldwide. It's common enough that we all have reasonable experience with it. It complicates 1 in 1,000 term live births. That's moderate or severe hypoxic ischemic encephalopathy. And it's important because the results following that insult are bad. More than 25% of babies undergoing this degree of HIE die. And amongst survivors, the neurological sequelae are common and severe. So more than 25% again are having big problems that last a lifetime: cerebral palsy, intellectual impairment, and seizures. And even those without those big problems are affected through at least their school life and beyond. They have milder cognitive impairments. And these are associated with behavioural and educational difficulties. Last a long time. So it's a big problem, therefore it's worth trying to find the best solution. I can't compete with Jerry's description of the science of hypoxic ischemic encephalopathy and cooling, but this is my dummy's guide. I don't know how that translates to Polish or other European languages, but this is my very basic understanding of the basic science underlying the mechanism of cooling. So the important thing is that if you subject a brain cell to stress and you cause it to die, then this happens in 2 phases. You have following a severe insult, this initial phase, immediate neuronal death, cellular hypoxia, primary energy failure, and then you have a secondary phase, a delayed neuronal death, and this occurs at least 6 hours later. And the importance of this from in relation to the topic today is that this gives us a therapeutic window. It gives us time to act, to try and salvage those neurons. And it's important because it's that secondary phase that accounts for the major proportion of cell loss. If you look at the pathology under the microscope, you see things like hyperemia, edema of the cells, the mitochondria fail, cytotoxins accumulate. We've heard about apoptosis, nitric oxide synthesis, and free radical damage. So all sorts of things are happening during this secondary phase of damage. What we see from the outside when we're looking at the baby is the signs of encephalopathy and seizures. The mechanism of protection we've already heard about. It's multiple potential reasons, and probably it's a combination of all these. It seems cooling seems to help prevent apoptosis, allows cells that would otherwise have died through apoptosis to survive. By cooling the nerve cells down, reduces the metabolic rate, reduces the release of excitatory amino acids like glutamate and dopamine, and it dampens down the production of nitric oxide and free radicals. So multi-pronged approach to saving these neurons in their secondary phase. Now, we've heard that there are 2 basic and contrasting methods of cooling newborns, and both of them have sound biological reasons why they might work. The proponents of selective head cooling, along with some mild systemic hypothermia, say, well, cool the brain more than the body because it's the brain that produces most of the heat. And if you cool the brain in isolation or predominantly in isolation, then you'll reduce the systemic effect, reduce the adverse effects of systemic cooling. That makes some sort of sense. Those who say, well, you must cool the whole body, say if you're going to cool the deep structures of the brain, you've got to cool the whole human being or the whole animal. The core body temperature and the deep brain temperature are similar. So if you want to cool the deep brain, you have to cool the body, and there's some mathematical modelling to support this. Any good idea in medicine has the propensity to take off and be widely accepted, but we were aware from the very beginning that cooling affects just about every organ in the body, and therefore it was very important at the beginning of this process of evaluating cooling to consider the adverse effects as well as the potential beneficial effects on the brain. So cooling affects the heart, and we've already heard about PPHN, persistent pulmonary hypertension, bradycardia, decreases the contractility and blood pressure. So a big potential problem there. Likewise, affects the lungs and can cause pulmonary edema, leading to hypoxia. Perhaps a potential risk of increasing neck. Certainly a very real risk of hematological problems like coagulopathy. And significant effects on the metabolic system, increasing acidosis, moving the oxygen dissociation curve to the left, and electrolyte and sugar disturbances. And by dampening down the immune system, perhaps an increased risk of sepsis. So when we're thinking of cooling and the beneficial effects of the brain, it's important, and I think Jerry's already alluded to this, that we are conscious of the potential adverse effects as well. I'm going to go through the randomised trials again, a little bit more attention to some than others, but to emphasise the consistency of the randomised trials that have been done in this area. Very early on, this magic figure of 6 hours came up, and by and large, all the randomised trials have enrolled babies in that critical 6-hour window. They've all been term or very close to term newborn infants. All have enrolled babies with moderate to severe encephalopathy. Some have used the amplitude integrated EEG as an enrolment criteria, and we'll discuss that in a little bit. All have had some evidence of peripartum hypoxic ischemia, so it's not just every baby that appears encephalopathic that gets into these randomised trials. There has to be evidence of an insult that occurs around the time of birth. And the typical evidence that these trials looked for, and they're pretty consistent across the trials, in the APGAR score. Now, having said that the APGAR score has limitations yesterday, to say that the APGAR score is 5 or less at 10 minutes of age, I think we can all recognise that this is a baby who's severely depressed. Babies were included in these trials if they needed mechanical ventilation or resuscitation at 10 minutes. And then some evidence of acidosis, either on a cord pH, and typically that's less than 7.1, or an arterial pH after delivery of less than 7.1, or a base deficit of 12 or more within the first 60 minutes of birth. All of the randomised trials excluded babies with congenital abnormality or active bleeding, so they're aware of the potential for coagulopathy, and all excluded babies who were in extremis, so babies who were not expected to survive. Okay, so and they all compared therapeutic hypothermia with the standard no cooling approach. And as we've heard, either the selective head cooling, or this is an ice baby, and we'll come to that shortly, being systemically cooled. Again, consistency in the outcomes across the trials. all of them. And this was a very good feature of these trials. They focused not just on in-hospital outcomes, not just does it save lives, but what is the long-term outcome? What's important to families, to the children, to society? Well, it's not only whether you live or die, it's what you're going to be functioning like for the rest of your life. And so long-term, that's a bit of a misnomer, but follow-up at least to 18 months was mandatory in all of these randomised trials looking for major neurodevelopmental disability. The secondary outcomes in all of these trials were those individual components, so death, major neurodevelopmental disability, cerebral palsy, cognitive delay, blindness and deafness. And then all of these trials looked at those side effects that we mentioned earlier, to do with the heart, to do with the coagulopathy, etc. These are in chronological order the larger published trials. When we say larger, they're not big trials in neonatal terms. Most trials that prove something to be effective in neonatology are well into the many hundreds of babies, into the thousands of babies. When we think about the things like the caffeine trial or the indomethacin trial, at least 1,000 babies, sometimes 2,000 babies. So while these are the larger trials, they're really not that large. Toby up to 325 babies. So I'm not surprised when individual trials don't show an effect, because I wouldn't expect them to, because they're not huge. So these were the original trials, as Jerry's mentioned, starting with the New Zealand CoolCap trial. Some of these trials, including the CoolCap trial, had amplitude integrated EEG as part of their assessment before enrolment. Mixtures of methods of cooling and a very consistent primary outcome, death or severe disability at 18 months. Then the later generation of trials, the Chinese trial, George Simbrunner's trial and the ICE trial, again, not large trials. 129, 221 babies. Reasonable size, but not huge trials. And again, this mixture of trials that needed amplitude integrated EEG or not, and this mixture of head and systemic cooling. The ICE trial went out to 2 years of age, but the others all assessing their babies at 18 months. So George's assigned topic, and I've gone a bit broader than that, is to tell you about the ICE trial and to acknowledge my colleague, Dr. Sue Jacobs, who works with me in Melbourne, who ran this trial. And I have the greatest admiration for people who are able to get people from all over the world to contribute to a trial like this. Never great numbers of babies from each unit, so very difficult to build up momentum in a trial like this, but nevertheless Sue persisted as the other primary authors did and have achieved a great thing. What's a little bit special about the ICE trial is it addresses babies where they're born. And at least in our country, and I suspect in many countries around the world, the majority of the burden of illness is not at our advanced, well-staffed, great obstetrician units in the middle of large cities. That's not where the babies with hypoxic ischemic encephalopathy come from. They come from the smaller centres, the centres that don't have a lot of obstetric experience, don't have paediatricians on hand to come and resuscitate these babies effectively. And so it's important that the trials address these babies because that's where the problems are, at least in our country, I suspect in much of the developing world, and probably I'll be interested to get my colleagues' impression on this, but even in Europe and North America. So that's one part of the background of this trial. The other is the timing of onset, and we've heard from Jerry that 6 hours is this magic window. Here's some more evidence. This is the New Zealand LAM data again. showing that if you start within a couple of hours of the insult, you get maximum benefit from cooling. Out to 5.5 hours, you still get a reasonable effect, but beyond 8 hours, very little effect of cooling. And so it's important that when we start as soon as possible. Okay, so this is the ICE trial, and it's a trial that looked at a simple method of delivering whole body hypothermia, getting babies down to around 33.5 degrees Celsius. This typical 72-hour period that most of the other trials have used, coming down a little bit in gestational age, down to 35 weeks, so including the upper range of the preterm population. And a very pragmatic trial, clinical entry criteria. There was no thought of using AEEG in these babies. So clinical eligibility criteria, simple method of hypothermia, and getting the treatment started at the hospital where the baby was born. So starting as soon as possible, that is within 6 hours. Started by the transport team and continued through the transport, getting the baby back to the major hospital. And this was a large international multi-centred trial. So babies at least 35 weeks gestation, having moderate or severe encephalopathy. Babies had to have at least 2 points of evidence for perinatal hypoxic ischemia, so either in terms of the APGAR score, less than or equal to 5 at 10 minutes, needing ventilation at 10 minutes, or a pH, and this was a slightly more stringent pH criteria, less than 7, or base excess greater than -12 within an hour of birth. And of course, these babies had to be either treated or brought to one of the large centres participating in the trial. It's who is left out of a trial that's sometimes as important as who is left in. So babies where the hypothermia could not be started within 6 hours were excluded. Little babies less than 2 kilos excluded. Babies with major congenital abnormalities, whether they were neuromuscular or suspected chromosomal problems, life-threatening cardiovascular or respiratory abnormalities, babies with coagulopathy, or somewhat strangely imperforate anus, but that pertained to our method of measuring temperature. We excluded, and this gets back to the pulmonary hypertension argument, babies who were requiring more than 80% oxygen, because they were already in dire straits. They were already in a lot of difficulty. If they got more severe pulmonary hypertension on top of that, they were at major risk of the cooling doing more harm than good. Excluded in extremis babies, severe hypotension, severe acidosis that we couldn't manage, and babies who had any cooling before the parents were approached for consent. So all babies were assessed for eligibility at the birth hospital, so that was easy. If it was in one of our big centres, the study investigator went along and said this baby's eligible or not. More difficult in the outborn babies. It was the retrieval team, the team of doctors or nurses going out to pick the baby up. They got the consent, they randomised the baby, they started the treatment at that small hospital, and then continued the treatment through to transport to the large intensive care unit. So the control babies are kept in what we would consider a reasonable range of temperature, 36.8 to 37.3, measured rectally. The cooled group, this pertains to the method of cooling, not able to be as accurately maintained as perhaps we are able to do now, but trying to keep babies in this range of 33 to 34 for 72 hours. How did we do it? Well, as you all know, many of these babies cool themselves. So just by turning the radiant warmer off, babies cool passively. They come down to the environmental temperature. If that was insufficient to get them down to that 33, 34 range, then a very simple method, just using gel packs. I'm not sure how that translates into the European situation, but just the packs that are kept in the refrigerator, wrapped around the chest and abdomen and under the head and shoulders. So simple, very inexpensive, widely applicable treatment that was tested in this way. At the end of the 72 hours, babies rewarmed by up to 0.5 degree every 2 hours. And this is the flow chart. So it's interesting always to see how you get down to the final numbers. So at the end of the day, we're down to just over 200 babies out of a total of more than 500 that were assessed for eligibility. Many of them didn't quite meet those inclusion criteria. There were some parents refused consent, and eventually getting down to 211 that were randomised. Very good follow-up rates. Only 3 babies in the cooled group lost to follow-up, 10 in the control group, and so left us with that 208 babies analysed at the end of the trial. So these are the babies' characteristics. As you'd expect, they're close to 40 weeks gestational age. Their average size around the 3 to 3.5 kilo mark. Slight predominance of males. Almost 2/3 of the babies in both groups are outborn, so born in the smaller hospitals. They were enrolled well within the 6-hour window in both groups, and they had normal temperatures at the moment of randomisation. So this describes the population, and it shows you that the groups were very similar. These were very sick babies. There was nothing subtle about these babies. They had APGAR scores of 1 at 1 minute, only 4 by 10 minutes on average. All of the babies were ventilated. About 2/3 of them required cardiac compressions, and 1/3 to 1/2 of them required adrenaline. So these are not borderline babies. These are babies who were very unwell at the moment in the first minutes of life and needed a lot of support. In terms of the enrolment criteria, so more than 80% had that APGAR score less than or equal to 5 at 10 minutes, almost all requiring ventilation at 10 minutes, an average pH of 6.9 and base deficit around the -20 mark. So biochemically, these are very severely affected babies. Most of the babies, moderate to severe, about 1/4 of them in the severe group of encephalopathy, and about 1/3 having clinical seizures. So as I said, the primary outcome, the follow-up rates were very high. More than 90% babies had data available for the primary outcome, and the bottom line was consistent with the other trials. Hypothermia significantly reduced that primary outcome, death or major sensory neural disability at 2 years of age, from 66% in the control group to 51% in the cooled group. Gives you an absolute reduction of 15% and a number needed to treat of 7. So cool 7 babies to produce 1 intact survivor. So this was statistically significant, the difference, and an important, significant result. If we break the results down into the components of that primary outcome, so mortality is reduced by 14%, so another number needed to treat of 7, so reduction from 39% to 25% in the cool group for mortality. The adverse effects of hypothermia, and I guess this has been the big surprise, has been the lack of adverse effects in most of the trials, and the ICE trial was no exception. There were only 6 babies in the entire cooled group that had to stop the intervention, 3 with bleeding, 1 because the parents lost heart, and 2 where the clinicians lost interest. So there were very few babies that actually left the trial because of problems with the hypothermia. The other things that we worry about as being side effects of hypothermia, really no statistically significant differences in between the two groups, and really no hints of any problems with the need for inotropes, almost identical. Slight increase in need for treatment for coagulopathy, but not statistically significant. No problems with thrombocytopenia, kidney function, liver function. Seizures very similar. Sepsis very similar. So perhaps a little bit surprising that the secondary or the adverse effects of hypothermia were in fact reasonably light. Okay, so this is what I think makes ICE an important trial. It deals with whole body cooling, showed no major adverse effects, and the results were consistent with the other trials that had gone before in the meta-analysis. And this is the only one of the larger trials that enrolled a substantial proportion of babies enrolled in smaller hospitals. We think at the end of the day, this ICE method, this very simple method of delivering cooling, is effective, it's safe, widely applicable throughout the world, including the developing world. It's a simple enrolment criteria, so you don't need to have high-tech AEEGs to identify babies at risk. Simple, inexpensive method of whole-body hypothermia, and as I said, can be used in non-tertiary centres. So moving on to the systematic reviews, and I'd just like to go through our review in a little bit more detail. The initial one was published in 2007, and what I'm going to go into a bit more detail today is the updated review that now has 12 randomised trials, 1,500 babies. So we're starting to get the numbers of babies that we need to really evaluate this treatment. A mixture of trials 7 of whole body, 5 of selective head cooling. Okay, so this is the primary outcome across all the studies. And you'll see that we've divided the trials up into the selective head cooling group at the top and the whole body cooling trials down the bottom, and then the overall meta-analysis, the overall pooled analysis. So you can see that it's quite clear, as Jerry said, cooling works. It leads to less death, less disability in the combination. What has now become apparent is that both treatments work. Both of these pooled analysis for the selective group, the whole body cooling, are well to the left of the line of no effect. The 95% confidence intervals are well clear. In fact, the absolute numbers are almost identical, 0.77 for selective head cooling, 0.75 for the whole body cooling. The other thing I'd like to draw your attention to is the homogeneity of these results, and I might get into trouble for saying this, but I think there's no evidence looking at these trials to say that one was any better at reducing cooling than any of the others. Statistically, we can do that by looking at measures of heterogeneity. We call this the I-squared statistic. If the I-squared statistic is more than 25%, we know there is problems with the trials. There are different results from different trials, but the I-squared figure for the overall meta-analysis here is 0. So no evidence of substantial heterogeneity between the trials, whether it's individual trials within the different treatment groups or across the whole range. So no evidence that one trial was better or worse than the others. No evidence that selective head cooling was better than whole body cooling. I'm a little bit suspicious of some of these post hoc trials that have looked at babies not in a randomised fashion, that compared systemic and selective head cooling. I'm not sure that we can get more information from them. So this is mortality, and again, the results are very similar. Both selective head cooling and whole body cooling to the left of the line of unity, so both methods save babies' lives. The worry at the beginning of this exercise was that cooling might be a great therapy and save lives, but lead to increased numbers of disabled survivors. And so that was something that I think everybody was very very keen on seeing the results of. And the results are very reassuring. So even within the survivors of these survivors of these treatments, the disability rate is reduced in babies who were cooled. So not only death by itself, but disability by itself were improved by the use of cooling. And to get back to this issue of, well, should we cool babies with severe encephalopathy? I think the answer is yes. If we're going to treat them actively, we should cool them, because they're in this subgroup of babies. Sorry, in this subgroup of babies, the pooled analysis, once again, is well to the left of the line of unity. The risk ratio is 0.75. These are the sickest babies, the most severe encephalopathy. They have reduced death or disability as much as the moderate babies do. So summarising, again, primary outcome reduced in the pooled analysis. I guess what we need to keep remembering is that even though this is a statistically significant result, very effective, you only need to treat 7 babies, our results are not good. 46% of babies in the cooled group either ended up dead or disabled. Better off than if they had not been cooled, but still we've got a long way to go. Still much more needs to be done. And without labouring the point, improvements in mortality, less major disability in survivors, all statistically significant. Less cerebral palsy, less neuromotor delay, less neurodevelopmental delay, all of those highly statistically significant. So whether you're talking about thinking or moving, all of those are improved with cooling. Blindness and deafness are quite rare outcomes, trends favouring the cooled group in both, but not statistically significant. So this was our summary at the end of this Cochrane review process, and there's some important messages within the details here. And the first line is important. When used within strict protocols, in tertiary, in ICUs, therapeutic hypothermia is beneficial to near-term and term babies with moderate or severe hypoxic ischemic encephalopathy. The important thing there is within strict protocols, and Jerry sort of introduced this topic. It's cooling by itself. It's not something you just roll out and hope for the best. It has to be done in a strict way. The protocols used in each of these trials are very similar. So if you're looking to start cooling in your centre or modify your cooling protocol, look at what worked in the trials and use that would be my suggestion. It's clear that the benefits outweigh the risks. From that very large list of potential problems of organs being affected adversely by cooling, we saw in the real world very few problems. A little bit of sinus bradycardia, a little bit of thrombocytopenia, but completely outweighed by the benefits. And I think I'm convinced that both whole body and selective head cooling are both effective. I would come up with the same recommendation as Jerry, but perhaps for different reasons. I like whole body cooling because it's simple. It's cheaper. Anybody can do it. You don't have to have that expensive cooling cap. So that's the end of cooling, and I don't think there will be any more cooling versus non-cooling trials. I think we have the answer, but of course there are many more questions that automatically flow from this. we're always asked the question, well, what if we don't see the baby until 7 hours or 8 hours or 9 hours or 12 hours? Is it still worth cooling the baby? The animal evidence tends to suggest not, but it's very difficult to look parents in the eye at 6.5 hours and say, sorry, your baby's not eligible for this treatment that seems to work if we'd got to you half an hour earlier. There are trials now looking at late hypothermia, so cooling started beyond 6 hours, and these trials will be followed with interest. There's another fairly obvious next step. If cooling to 33 or 34 degrees works well, maybe cooling a little bit more works even better. If cooling for 3 days works, maybe we should be cooling for 5 days or 7 days. And so there are randomised trials underway to compare the depth and the duration of cooling, and I think those will be very important trials. Refining it, can we apply it to preterm babies? Trials underway to do that. And Jerry's already commented on the cocktails with ice concept. Clearly, the rate of bad outcomes, even in the cool group, leaves us lots of opportunities to find new therapies that might help. Of all of these, xenon to me is technically difficult and fairly expensive. It's looking like it might be effective, but I'm finding it hard to see how that's going to be easily applied worldwide. Melatonin, I think, is a very promising drug, much more easy to administer, some evidence from animals that it may be useful. And ultimately, stem cells, the treatment for everything. So where have we got to? We've made a lot of progress since 1997, when it was said hypothermia, most promising option for a clinically feasible neural rescue therapy in encephalopathic newborns following acute perinatal asphyxia. And I think this is an example of we as a neonatal community have got it right. We've taken this promising therapy and within a relatively short time, but with a massive effort, many people around the world, we've nailed this new therapy. Therapeutic hypothermia improves outcomes after moderate or severe HIE, but we've still got a long way to go. 46%, almost half of these patients still have a very unsatisfactory outcome. Strategies that are needed, we need in our country, and I suspect in yours as well, regional guidelines, so guidelines that go out into the community to facilitate earlier starting of cooling. We need to think about refining our current hypothermia methods and look and test synergistic neuroprotective therapies. And just to show that we have snow in Australia too, this is our local cross-country skiing place. But you can see in Australia, even when it's snow, it's still warm. Anyway, people have kept apologising. They say you must come back to our country in the spring or the summer, but this is beautiful. You take it for granted, but to walk through a city that's covered in snow, for a person like me, it's been a real treat. So I'll stop there. Thank you for your attention. What do you think, Andreas? We get the crew up or for some questions, or do that later? One more talk. Okay. Okay. So maybe if there's any burning questions, happy to take them. Otherwise, we'll have a little panel discussion after the third talk after coffee. Burning questions? How do I get to coffee the fastest? Okay. Thanks very much.